So let's talk a little bit about personalizing care. And you all talked about things in a little bit different. So let's start with newly diagnosed patients. So some changes are happening, right? You're seeing quad therapies or instead of triplet therapies, but what would you say are the most important new strategies for newly diagnosed patients and new trends that you're all seeing?
I got the mic. I guess I'll start. Yeah, I think so. In the past couple of years, I think one of the biggest changes that I've incorporated into my routine care is the use of a drug called Darzalex daratumumab, particularly in our more frail patients. So again, these might be patients that aren't heading towards a transplant. Maybe they're coming in with a lot of medical problems. And the ability for that combination, again, with the Revlimid drug and the dexamethasone that you've heard a lot about, to generate good remissions and to do so without a lot of side effects has been pretty profound. So I think that's one comment I would make. You asked about quads. That's again 4 drug combinations. We are incorporating more of that, but one of the challenges with myeloma, in my opinion, is as you layer more treatments, even if they aren't causing significant side effects like nerve pain or neuropathy or cardiovascular problems, it does suppress the immune system, and we do see more infections. So kind of in real practice, I think that's not going to be an option for many patients, but it is something that if you're eligible, can definitely produce good remissions and better outcomes. And I guess I'll pass to.
I guess for me, the biggest change in my thinking over the last decade is the way I approach maintenance therapy. 10 years ago, it was a year of maintenance, then it was 2 years of maintenance, and it's 3 years of maintenance, and now it's kind of like long-term, pending information that would suggest that I could stop early. I've been using maintenance indefinitely. The other piece is adapting the maintenance based on the genetic risk. I've started using 2 medications for maintenance in patients who have high-risk disease because I'm not quite serving them adequately by using 1 medication for maintenance.
Yeah, I think I agree with both of these points. Maintenance has been a huge shift in our practice, and then what we do up front, I think I'm basically left with what we're missing, I think. And so I agree with both of these practice changes. I think we really need to work harder in high-risk disease because all we're doing is adding more and not really addressing biology. I do exactly the same thing. I add an extra drug, and I ask myself, am I really shifting disease biology? Because what we're really doing is treating standard risk patients really, really, really well. And we're leaving behind that quarter of patients or so that have high risk that we don't have to say at all understand. We haven't passed out what actually is high risk disease. And then to speak, I guess, about the future, the next step, maybe we'll see after autologous transplant that we have a decent immune system. And maybe this is an ideal place to position some of the newer immunotherapies. And so I think that needs a lot of scientific translational work to be put in the context of trials so we understand exactly who's responding to what, which unfortunately we don't really have as well right now.
So to your point about this personalized therapy and maybe high-risk patients having additional need at diagnosis, does somebody want to address the importance of like first remission is longest remission? And then how do you maximize that remission? When you look at your standard risk versus your high-risk patients and you look at their genetics, what do you suggest that's different versus like, RVD, transplant, Revlimid? What's different for your high-risk patients in that standard therapy?
Okay, so to talk about, for me, high-risk disease, I do exactly what Dr. Gertz suggested. So we put our foot on the gas, we try and get a deep response in induction, we transplant, and we strongly encourage people not to forgo a transplant in that situation. I think it's a terrible idea. And then we try and maximize maintenance to get patients who aren't in a really deep remission to a really deep remission, and we don't stop. And so we don't have an endpoint, but I do exactly the same. And I tell patients, as long as this works, we need to maximize that first remission, and we're just going to keep going. So it obviously is an important question in the field, who to stop in. I think one of our big problems biologically is we throw a bunch of different disease biologies into this high risk. And we really need to understand the difference between, hey, is there a difference between 414 and 17p? And those supposedly stage 1 patients who for some reason relapse after a year that we can't capture. So I think before we start to do trials in high risk, which we already are doing, I personally have this philosophical thing where we need to understand it better before we start to say this is a good idea for you as high risk, because I don't think we're quite there yet for risk adaptive therapy. And I mean, I think this is a contentious point. So I hope there's some disagreement here.
I don't disagree. I don't think I have anything to add to that, frankly.
Yeah, I just would say anecdotally, I just spent about 6 months trying to write a review paper on high-risk disease and myeloma and how do we define it and what are our tools. And I probably came at the way from the end of that being more confused and more confident in my assessment. So I guess one of the things that I would hope is we do have, with new technologies, we do have some ways to do kind of some deeper dives into the genomics, meaning kind of sequencing all the genes in your myeloma cells, as opposed to just when we do something called a FISH study, we're looking for, like Dr. Patel said, deletion 17p. We know that's high risk, but we're going to go fish for it. We're going to try to find it. My hope would be in the coming maybe 5 to 10 years, we can start to, again, as hard as this may be, standardize some of these genetic testing and get a little bit more of a deep dive into each individual patient. I think right now the problem with that is that may be able to be done in an academic center, but that's not going to be useful in the community where the resources aren't there. So it's a huge challenge and probably not one with an easy answer anytime soon.
Are there any clinical trials that are appealing to you for high-risk newly diagnosed patients? I know that like I've seen some isatuximab in there. I've seen some maybe some CAR T even like for newly diagnosed. I don't know if the bispecifics have. I haven't seen that so far, but maybe I'm just missing them. What clinical trial type strategies are in place?
Yeah, I guess I would echo what Dr. Patel said. I think off of a clinical trial, I would say one thing is, high dose chemotherapy and transplant has been one thing that has been shown to be beneficial. I think there are some interesting trials going on right now trying to incorporate some of our new kind of immune therapies. So you're going to hear about CAR T later, but in lieu of a transplant, might CAR T be a good option for someone earlier? Or after a transplant, if you're a high-risk patient and we're not able to get you into a good remission, that's probably not a good situation. So should we do a CAR T therapy after a transplant? Or again, some of these, we call them bispecific. So drugs that engage your immune system to get after the cancer, because the biology of high-risk myeloma is very different than the biology of a standard risk patient. So just kind of throwing the newer drugs and the drug classes that we already know at that patient probably isn't going to lead to the outcomes we want. So there's a lot of work being done in the areas, but these trials are going to take some time, and I do think we're excited that maybe there'll be some impact, but we just don't know yet.
And what about just the options of clinical trials? Like, do you suggest that your patients consider clinical trials at all stages, newly diagnosed and relapsed and, in other situations?
When you look at clinical trials, what we're really talking about are groups of global thought leaders in multiple myeloma getting together to try and devise what will be the next big thing in multiple myeloma. No one's getting together to try and figure out what's going to fail, but to push the envelope and improve outcomes over time. And so participation in clinical trials is really an amazing opportunity to get in on the ground floor of the next big thing. When Revlimid and Velcade underwent trial 2003-2004, it was melphalan, prednisone, Revlimid, melphalan, prednisone, Velcade, which were started, and people who didn't participate in clinical trials got melphalan and prednisone. And people who did participate in clinical trials were able to access these experimental drugs, Revlimid and Velcade, and that's 17 years ago. And so participation in these clinical trials is essentially, in my own mind, taking advantage of what the smartest minds in myeloma think will be effective. And I think that individuals who have the opportunity to participate in a clinical trial and don't have actually done themselves a disservice.
Can't agree more. I think our major challenges it's almost a shame for us if we don't have that study and we know something's going to be released. We need to make sure actually that access is available to more people. So, if we talk about, for example, the Revlimid and Velcade when there was nothing else, CAR T now, when there's nothing else other than cytotoxic chemotherapy. So having access to those studies is super important, but I can't agree more with you.
Well, even access, as I was considering like a very slow relapse and what I was going to do next, I joined a CAR T clinical trial, and I'm so happy I did, because it's hard there's a really long waiting list right now for CAR T. So had I, just waited for it to get FDA approved, I may or may not have gotten that in the next 2 even plus years.
There's actually more to it than that, though. Some of the current, in my opinion, investigational CAR T trials with these up and coming agents, to me, look actually better than what's commercially available. So in fact, it's not a question only of access. It actually could turn out to be quite superior.
Okay, great. So let's talk about transplant strategies. I know you'll get this question a lot. So, and somebody addressed it a little bit, and I know you probably will in CAR T. We talked about it last night too. Transplant strategies. So when I was diagnosed, it was kind of this debate between single versus tandem transplants. So a question for you, Dr. Hagen, like, is tandem still used? And in what situations is it appropriate? And then everybody wants to know, oh, is CAR T going to replace stem cell transplant? Since we talked about transplant so much this morning.
Two very straightforward questions. So what's the biggest access to a tandem transplant? It's not the clinical benefit. It's actually the fact that Medicare only covers one transplant. So if you were diagnosed prior to the age of 65 and you got a transplant and your myeloma comes back 4 or 5 years later, we would consider you for a second transplant, for example. But if you're over the age of 65 and your insurance is Medicare based, tandem transplantation is not an option. So unfortunately, I know we keep harping on this, but it is really important. If you look at where tandem transplants are being done, they're generally being done in centers that have a lot of commercial payers, and that's just unavoidable. There is a benefit for tandem transplant, in my opinion, in high-risk patients who achieve so the biggest benefit, in my opinion, is in high-risk patients who achieve a good response from that first transplant, meaning you're coming in, maybe your myeloma started with 40% plasma cells in the bone marrow. We do a first transplant that gets way knocked down to 1%. We can still detect a little myeloma in the bone marrow. In a patient who had a really smooth course with a first transplant, that's when I would consider it. Will CAR T replace stem cell transplant? My hope is that maybe one day it will. The fact of the matter is, with a CAR T therapy, you're having to biologically engineer a T cell, and that is just a lot more complicated than giving somebody 5 days of Neupogen, of Granix, stimulating their bone marrow, collecting stem cells, and doing a transplant. It's why autologous transplants can be done in very resource-poor settings, really around the world. So I think the challenge with CAR T is not, is it a great therapy? It's definitely a great therapy. Patients who've had 7+ lines of therapy going into MRD negative remissions, we don't see that with anything else. But access, in my opinion, will be the rate limiting factor to that for sure.
Our group is one of the largest myeloma groups in the world, and internally, we don't have a consensus on 1 or 2 transplants. So unfortunately, it depends on the individual that you actually see. And the problem is that the science doesn't guide very well. So there's studies that were done in France that demonstrated that in high-risk patients, having 2 transplants right after diagnosis improved survival. And then there was a US trial that called Stamina, if you want to Google it, that looked at 1 versus 2 transplants and didn't see any difference in survival. So you have 2 diametrically opposed results. Trials are different. The availability of agents and medications at diagnosis in France or in the EU is very different than in the United States. And the entry criteria of what you could receive before getting into the trial were very different. So you can't necessarily compare the trials that one's right and one's wrong, but based on their eligibility, they may both be right for their individual populations. But the problem is, it's not very straightforward to know whether 1 or 2 transplants for that high-risk population is appropriate. And I mean, speaking for myself, actually, I've kind of stopped doing tandem transplants, But I have people who are to the right and to the left of my office who will do a tandem transplant. And these are, well, look, these are honest disagreements among well-meaning physicians who are trying to do their best, but the just science isn't there for definitive answers.
Okay, one other question on personalized care. So at the recent AACR conference, there was a lot of talk about organoids. So maybe somebody wants to describe what that is, but we funded an organoid project in myeloma. And I think the idea is to determine personally what drugs are going to work for me, maybe at my relapse. What's my myeloma most sensitive to? What's it already not going to respond to? Because when we think about taking 4 drugs at a time or whatever, the expense and the side effect profile and all that is not super awesome. So, you know, how do we do, are there new technologies like this that we can determine, oh, this drug might not work for me, or maybe it's going to work great, or in this particular combination, are there techniques like organoids or something else that might be better for us to determine personalized care?
We absolutely need more of those studies, because we have no idea when we're giving anyone any agents who's going to respond. Really no idea, I think. So we need more of those studies. So organoids are basically, you take someone's marrow and you try in the lab, try and grow basically a tumor, and then you treat it and see the response in the lab. And there are other similar types of technologies that people are trying to use. There are some great investigators trying to do in vitro assays. There are companies who are trying to do this. Certainly in the solid tumor world, it's become a big deal to do these things. So there's a lot of interest in this area. I don't think we're quite there yet. I'm being nice.
You'll pass the mic.
Yeah. And we should also, to think outside the box, it's not always, I think, going to be something like, hey, treating something in vitro. There is already some work out there on other factors that we could look at. We just haven't advanced these biomarkers into the clinic.
It's over 50 years since Sid Salmon, who was the cancer center director at the University of Arizona, first tried to predict which medications will work for myeloma patients based on the growth of myeloma cells in the test tube. That failed miserably. And I think it's quite challenging, and I think it's dangerous right today to make clinical decisions based on test tube measurements. First of all, myeloma is notoriously hard to grow in the test tube. So we talked about these weeds, and these weeds, they need bone marrow soil to grow. And those weeds that grow without that bone marrow soil, they're different than the average weeds. And so they're often not predictive. The only thing that I actually believe would be predictive, but is not something that, for reasons unclear to me, is that there's a protein called cereblon made by genes called Icaros, that if you don't have that protein, Revlimid generally will not work. But we don't really, in practice, and I don't know why that is, measure for that to see if it's worthwhile to give the Revlimid or not.
Okay, last question. We talked about maintenance therapy, and especially for high-risk patients, doing a doublet for maintenance therapy. You see kind of the new development of these cell mods coming up. You see other things like isatuximab, daratumumab being used as maintenance therapy. I think proteasome inhibitors maybe not so effective as maintenance therapy, but in some cases maybe. So do you want to talk about maintenance therapy and how do you pick?
Yeah, it's a good question. I know we've kind of said this several times, but I think it's important to contextualize what's the standard right now. So again, the standard right now is to just get Revlimid or lenalidomide. And we've done other trials looking at different agents in maintenance. I think my takeaway is, in my opinion, is that generally drugs that just kill myeloma cells primarily, so your proteasome inhibitors like ixazomib and bortezomib, are less effective in maintenance because you don't have a lot of myeloma cells left to kill. Now, those drugs do engage the immune system to some degree, But when we look at our new monoclonal antibodies and Revlimid, and you're referring to some of the new generations of IMiDs here, those drugs work actually in many ways that we don't even understand yet, using them for 30 plus years or almost 30 years here. They work by keeping your immune system engaged against the cancer. So I think it is important to continue to look at those drugs in the maintenance setting, but I really get nervous when I see a clinical trial where, you have to make sure we're at least offering people as good as what we know now. Meaning, so if I see a clinical trial comparing Revlimid maintenance to something that hasn't even been studied in maintenance, that makes me a little bit skittish, and that's something that I wouldn't practice in routine care. But I think there is opportunities to improve how we approach maintenance, less toxic. I'll tell you, Revlimid is a very well tolerated drug, but it's pretty rare that I get a patient that comes in the clinic with no side effects from Revlimid at all. So again, I think that's an opportunity for improvement.
Okay, great. I always learn something new at every meeting.
Dr. Sivanasanka, could you come on up here and we'll do the Q&A. And if you guys can pass that mic around. So I hope you've been thinking about your questions. I've added, I also want to introduce Dr. Ataya Suvasanka, who's going to be speaking this afternoon, but I wanted her to be part of the Q&A. She is at Indiana University in Indianapolis. And so who's got a good question for us? You can stay seated and I'll hold the mic.
Thank you very much for being here today to answer our questions and share the latest in the research. I am curious as to whether or not, if you've had 2 stem cell transplants, if you can get a CAR T. I was told that the CAR T has toxic side effects, that 60 days out afterwards, some of the patients actually didn't know who they were and they were having these problems. So I'm wondering if it would be possible or probable that you could get this, and then the toxic risk.
Since I'm the new face in the team, I get to tackle the first one. So this CAR T that's being mentioned is literally the way to retrain the immune system by collecting the patient's very own T lymphocytes that don't recognize the cancer cells. And then there's a process to engineer these cells to then give them back into the patients and have them being able to go and attack the cancer cells. Classically, the T cells actually are functioning by fighting off things that don't belong to us. They just, in patients, don't recognize the cancer cells. So you imagine when those T cells that are trained start to kind of go after the cancer cells, thinking about having kind of flu-like symptoms, but times 10, for example. So there's this period called cytokine storm or cytokine release syndrome, where the T cells are going to fight the cancer cells, and there are all kinds of war happening inside the body. And that's really the primary side effects that people are talking about. Some of those side effects also end up involving the central nervous system and can cause autoimmunization in very severe cases. There's those coma people end up in the ICU. Luckily, these are now being recognized. They're also recognized earlier, and there are treatments for them. So I would say that while we're dealing with entirely new thing that gives us different set of side effects, on their own, they're manageable. So I wouldn't actually rule that out. And in fact, while we think about autologous transplant as something that's done in younger patients, on the CAR T cell side, because there isn't a huge suppression of the bone marrow, even in really people who've failed everything or older, it could still be an option for them. So I wouldn't rule that out.
And I also want to remind everybody, remember, we're going to close today with Dr. Gertz's detailed discussion of CAR T as well. So this will add to this.
I would just one tiny additional comment. When we're talking about CAR T therapy, it's important to look at it in the context of myeloma, because in lymphoma and leukemia, we've had a different spectrum of this CRS, and it's been much higher. So thankfully in myeloma, we see less of that. Not none, but definitely much less.
Question? Okay, we have some online. No. Oh, I am so sorry. I am blind too.
So have you guys noticed an uptick in any patients with extramedullary disease now that they're staying on maintenance for more extended periods of time?
And if you could explain what extramedullary disease is.
So extramedullary disease is disease outside of the bone marrow. So we talked a lot about that supportive environment that the myeloma cells need to grow. A point can come in the disease where that's not required anymore. And the disease can grow, I think, pretty much in any organ and can be seen outside the bone marrow essentially. So totally separate from disease that's, in my mind, totally separate from disease that's growing out of the bone and is next to the bone. This is disease that can be in other organs. I think it is, Greg started off by saying that we're all young. So I want to contextualize this and saying that I've only been doing this for a very short period of time because I am young. But over the time I've been doing it, I think we do see it more because we thankfully have people who get really good treatments and tend to live longer. I don't know, and I don't know if anyone knows of any data out there on whether there is an effect of giving some of the agents we give, some of the novel agents we give, on whether there are genetic changes that lead to extramedullary disease. I think this is a question for smarter folks on the panel than me. But yeah, I think that we definitely see more extramedullary disease than we used to, but I don't know if that's because people are going through more therapy.
I'm not young. And when transplant was first introduced, we clearly saw an increase in this ability of myeloma cells to grow outside the bone marrow in the liver or the lung or the soft tissues, the areas which normally, and then with the first introduction of the Revlimid and the Velcade, we saw an uptick again. And so myeloma cells are truly, they're really quite evil, and they have the ability to change over time. I mean, the myeloma you start with is never the myeloma you end with ever. And there is a consequence of living 3 years, 10 years, 15 years, and 20 years because the number of years you have at risk to develop unusual complications is changing. And I believe, I've seen it with every new advance with myeloma, that we've seen changes. The natural history of the disease changes when you're able to survive for these complications to develop. But I think it's true.
I'm going to ask a question that is follow-up because I don't understand it. So there's this data on giving people melphalan and inducing mutagenesis, which we all know this is the type of drug that we use in transplant. So this is kind of tied to that. Why don't we see worse outcomes? We actually see better outcomes if we're inducing more mutations and more genetic problems in the myeloma.
Well, they're competing risks. I mean, we're clearly seeing patients live longer, but this whole business about second cancers following transplant and Revlimid, this isn't done because we're seeing over the last 5 years, that's upticking. And we're seeing actually in our practice, a doubling of secondary hematologic malignancies, serious ones and crazy ones, such as acute lymphoblastic leukemia, which you never would guess in a million years, as well as all the other myeloid malignancies. It's not done. But at the end of the day, if you add up all the second cancers, it's about 6%. And in our practice, I'd say that the cause of death in a myeloma patient is myeloma 90% still.
If I could go back
Please.
to the extramedullary disease, I think one thing to always kind of think about it in the wheat story is, even though we think that all of the myeloma cells originate from the same original cell, as the cells divide, they acquired additional changes within, so all of the wheats are no longer the same. That concept is called clonal heterogeneity. This long name just means that whenever we come in hard with combinations of something to try to kill them as much as possible, the clone that's left behind were actually your stubborn weeds. And when they keep coming back, they're just tougher to get put back into rest, and they no longer behave in the same way that they originally started. And that's why it's important to be seen, to get those samples sequenced so that as the data become more available, you get to understand the specific signature of those clones, because otherwise we're always treating patients with what we haven't used before, but it wasn't specific to that signature that that particular patient has.
Question.
I just want to say that's an important point, and it's the reason why when patients have no symptoms, we don't treat them. Because just to change the paradigm, if you have a bladder infection and you get antibiotic A, it fixes the infection. You get the same infection, you use A again, it probably is going to work. But by the time the third or the fourth time, that antibiotic is going to stop working because you've basically killed all the sensitive bacteria in the urine, leaving just behind what is resistant. And so over a period of a quarter century, it became the fact that if you have bacteria in the urine and you have no symptoms, we ignore it because giving antibiotics is just going to result in bad bacteria. The same principles applying to multiple myeloma. You don't want to treat patients who don't have a problem, because one of the risks you're going to do is you'll kill everything with the medicine that works, and what you have left behind is where the stuff doesn't work, and that's not going to end well if you can scrape by some years of just monitoring and observation. Yes.
My sister was diagnosed with multiple myeloma, and she lived 12 years and died approximately 3 years ago. I'm a very curious person, and I'd never heard of multiple myeloma, so I looked into it. And what I learned, whether it's right or wrong, was that there was no DNA. It didn't go from family member to family member, and I wanted to know where it came from. And this is for Dr. Patel. She got taken care of at the Royal Marsden Hospital. And it was just amazing because I was at the last meeting that was in person, and there were these two veterans, and they'd been taken care of for a few years by the Veterans Association, and they had just come through with the fact that they believed that they got multiple myeloma due to Agent Orange. My brain, I still had a little bit left, said, that's environmental. So are you looking at the causes of multiple myeloma when it comes to environmental? I then had to ask myself, after I was diagnosed, what did my sister and I do that could possibly be environmental? We're both World War II babies, the East End of London, and our playground was the bomb sites. And if you go to London even today, the ground is filthy. They're still finding unexploded bombs. I think they found King Richard a few years ago under a parking lot. And there's still, you know, unexploded bombs, et cetera, et cetera. And if there was a piece of dirt around, people grew vegetables. So they're now eating the stuff that grew in this bad soil. It's looking at the environmental issues. Does that help you with what else it is that you're doing?
So there's definitely a link with Agent Orange. It's 100% service connected at the VA, right? Yeah. I think for many years, we've always said about many blood cancers, not just myeloma. Oh, yeah, this doesn't run in the family, this doesn't run in the family, and that's clearly wrong. And so the evolution of genomic techniques and being able to look at germline inherited DNA has definitely changed that paradigm. I think you'll ask all the panel members, yeah, I have some patients who have first-degree relatives. So there's still, I think, a lot to learn in that area. I think this is a very difficult disease to study. Environmental exposure in general, and drawing a clear line is very difficult. It needs large epidemiologic studies. It needs a lot of people to participate in enrolling in cohort studies. So those are not extremely easy to do. And what I think we know about this disease, there's probably 20 factors at play. So there's a huge amount of complexity. And added to that, there's a lot of folks who walk around with precursor diseases that we don't know of. So large efforts to look at those folks are going to, I think, help identify risk.
Since Dr. Patel was hinting to me, on the veteran side. So I also take care of veterans over at the Indianapolis VA. And there is the relationship to Agent Orange, not only myeloma, but a few other cancers as well. But going back to your point, why is it so hard to know what was the trigger? It's probably because at the time of exposure, was probably a number of years ago before someone eventually get diagnosed with myeloma. So this is why having patients being part of the research effort, because only patients are going to know where they have traveled, where they've lived, and so on, and to be able to plot out the history of exposure to the clusters of cancer, that would be helpful. Another point was about the family members. And it is true that there's increased risk of myeloma if you have family members with myeloma, but that risk is actually not very much. So right now, to recommend everyone to go out there and have screening tests to look for myeloma probably isn't very efficient, because on the other end, there are also people who live with small amount of abnormal plasma cells that never progress in their lifetime. Family members also breathe same air, eat same food. So it could very well also be not only genetic background, but common exposure.
And I guess the only thing I would add is, we are increasingly doing studies that are called registry studies, and I would really encourage all patients to join those if possible. And what those are is, it's not a study about the treatment we're going to give you, but you're just allowing us to follow you over time, to follow your genomics, to follow your disease course. And there's been a couple that have started to have some publication. These are large groups, thousands, sometimes tens of thousands of patients. And it's an opportunity for you as a patient to help us, but then also help your peers in the long term. So I think these are things that are worth asking your doctor about. They're frequently available even in the community setting. So you don't have to be at an academic center for many of them. And it's an opportunity, I think, for you to actively participate in the advancing of the care of myeloma patients.
And just to follow on that, that's what HealthTree Cure Hub is. And
Correct,
that's one of the
exactly.
reasons you want to be a part of that, to do exactly what Dr. Hagan was just talking about. So if you have a question, just signal me, but I'm going to read some online questions that have been submitted. I'm going to start with the simplest one first. How can leftover stored stem cells from an autologous transplant be used besides a second transplant?
It's a good question. We don't utilize them a lot outside of a second transplant. One pattern I think we've seen, I'd be curious what the other panelists would say, is with CAR T therapy and bone marrow, as they get progressively beat up over time from therapies that are toxic to the bone marrow, sometimes we will use them for what we refer to at least as a stem cell rescue, meaning to kind of get that bone marrow to get healthy again. But that's not a routine practice. It's not done that frequently, at least at our center.
We certainly use leftover stem cells to replant the garden in patients who have very poor garden growth. We do that both after extensive treatment. We do it also for those patients who have poor recovery of their blood counts after CAR T. And our consents, when we collect stem cells, allows those cells to be used for medical research if there's no possibility of the patient needing them anymore. And so we have cells that may or may not have plasma cells in them that's used for medical research.
Hold on. Hold on.
I have a question just about stem cell transplant using this. If the stem cells from a patient who has myeloma, the stem cell is supposedly in its infancy, correct?
They're primitive cells that are able to give rise to red blood cells and white blood cells and clotting cells.
But it also then grew and had the cancer show up?
Yeah, that's not correct. The stem cells that we're talking about are the stem cells that give rise to those three cell lines. Those stem cells cannot develop B cells, which is the parent cell of the plasma cell.
You lost me.
Sorry, the answer is no. The myeloma cell is not part of those stem cells.
Okay, so when you harvest the stem cells, okay, and you get enough for the second transplant, and you take mine, okay, can he use it?
So
Is that
that's
what you do? Or
that's
is
of no. that's a very different type of transplant. It's done where people get a transplant from a brother or a sister or a parent or a child. Its use in myeloma is very, very restricted because number one, the really long-term responses that are seen in leukemia don't evidence in myeloma. But there's a second issue here, is that when your seed cells are given to your father, there are immune cells in there that recognize your dad as not being you. And it launches an attack of your immune system on your father's body. That can be a very toxic, complicated process that limits the use. It's used a lot more in Europe, I think, than in the United States. I'll let my colleagues say if they're doing that type of transplant. We do it extremely infrequently because the long-term benefits are not super high and the toxicity is very different than using your own seed cells.
Yeah, I think it's basically disappeared outside of a few centers. And in my mind, it should happen most of the time in the context of a trial, and really those trials are disappearing. Yeah.
We have a COVID-related. Oh, I'm sorry. Did I cut you off?
Just in case.
I'm not going to
Please.
tackle allogeneic transplant of myeloma.
I'm sorry. So COVID-related question. Is it correct that COVID vaccinations and boosters impact the numbers of IgM and IgA? Are these numbers elevated due to vaccinations and boosters? And should we focus on kappa lambda numbers instead?
Yeah, I think so. What the question I think is really getting at is after you get a vaccine or something that stimulates your immune system, how do you then look at your myeloma numbers? And so I guess the simplest answer is with extreme caution. We do know that in some patients who get the COVID vaccine or really any vaccine can have a strong inflammatory response. So again, we don't want to overreact. And as Dr. Patel mentioned in his talk this morning, any one point in myeloma, looking at the blood works, the IgG, the light chains, you don't want to make a really strong decision. You need to look at things over time. So it's important to let your doctor know if you've had an immunization or really anything that could rev up your immune system as you're getting your myeloma labs checked so that they're aware of it.
I think we're lucky enough that the response to vaccines usually going to peak and then go down. So the repeat lab should clarify that. But the other test that Dr. Gertz had already mentioned that was specifically looking at something called M-spike is not looking at a general immune response to what it comes into contact with, but looking specifically at what the cancer cells make that should not be affected by vaccination. So that M-spike should still be something that's reliable. Now, I've had some patients, though, who got what they call PET-CT, a scan all over the body that's looking at hotspots. You could potentially see lymph node enlargement in patients who get their vaccination, particularly, so you could almost see the enlargement in the axillary lymph node in the armpit after the vaccine on that side. So just a point to not be too quick to call those enlargement of lymph nodes as the progression of disease.
Related to that, I'm sorry. Please explain what are neutralizing versus non-neutralizing antibodies within the context of COVID vaccines?
That's for sure.
Okay. Whoa. Okay, so first the word neutralizing is literally binding and getting rid of it, right? So when we say we have neutral, it means that this antibody is going to bind on to, for example, the COVID virus and antibody that's sort of giving in to boost up the immune system in general. So it doesn't just bind and eliminate, but increase the level of protection. That'll probably be how I see the two being different.
Oh, perfect. Yeah, I appreciate it.
I just think, we have to be careful about when we get information in our cancer care, making sure we're drawing conclusions that we are based on good sound data. So I guess how I would answer that question is I highly encourage all patients to be vaccinated and get their boosters per the CDC guidelines. And there are additional things that you can further protect yourself, like there's a drug called Evusheld that can be given in patients with weakened immune systems to help to protect them further. And I know that it's a great question, but again, a blood work and how that actually impacts a blood test that we don't know a lot about, even though COVID is probably the most studied thing in human history at this point, but we really don't know how to use that blood test to make any sort of recommendations or treatments, at least as of right now.
And I apologize to the online person who submit this in advance, whoever it was. It is a long case study here, but the question, and I'm not going to get into that, but the question I think is very relevant. How should myeloma patients make decisions about precision treatment using MRD or genomic analysis? So the other, should patients be focused on these things, or is this just for you?
Okay, to cut to the chase, there's no decision that could be made on MRD testing that we have any good data to back up. Absolutely get the test in the context of a clinical trial. Otherwise, I don't test it unless a patient specifically asks me for it. And I do caveat before, I do tell them before that I don't know what to do with the answer of that.
I just have to repeat that because that's so important, that currently today, there is no decision in clinical practice that you would make based on the MRD, not whether to intensify initial therapy, not whether to do or not do a transplant, whether to continue or stop maintenance therapy. Those are things that are in the research realm today, and they're important, I think, to understand the biology and the prognosis, but you are not, I am not, Dr. Patel is not making a clinical decision based on those results.
Take it.
Well, okay. So when it comes down to MRD, I don't know whether everyone actually know what it's all about. So we were talking about checking this M protein in the blood as a marker to know how many cancer cells are there in the bone marrow, right? And then we're talking about doing a bone marrow biopsy to really do the cell counting to know how many % of cancer cells are there. When we're talking about this MRD testing, it is actually trying to go deeper into saying, well, if the pathologist doesn't even see increased plasma cells, can we go use a more sensitive technique to classify those who are already achieving what we call a complete remission to a grade A and grade A++, if you might. For folks who we look very, very hard using sensitive technique and still don't see the cancer cells, those are folks who we're calling MRD negative. On the other hand, if everything looked good, but if we look hard, we can still find the cancer cells, that's MRD positive. So these are mostly allowing researchers and also your doctors to understand just how good of a remission you have. On its own, it doesn't always need to mean you're in a terrible shape. If you're MRD positive, you're still in complete remission. And that's really what we would want all of our patients to hopefully get there. Now, it might have some more meanings in patients who are so-called high-risk disease, because there are more opportunities on clinical trials. When we say people have high-risk disease, it means that we're worried that their cancer is just more aggressive. And we want to try to perhaps look for different ways to go to do a better job for those folks. So these are things that are being explored in clinical trial. I wouldn't lose sleep over the MRD status today.
So I'll again just emphasize it using my own metaphors. When I started, a pathologist would look at the garden under the microscope, and the best they could do, if let's say you started with 38% acreage weeds, the best they could do was 1 or 2%, 1 or 2 in 100, less than 5 in 100. Otherwise, with the visual looking and counting of weeds, you could say maybe 1 in 100 or 2 in 100. But with this new technology, now you can count 1 million cells, and you can do it in about 1.5 minutes. And you can say whether there's 0 out of 1 million, and that if it is 0, that is that MRD negative. But the issue is, okay, so you have 100 out of 1 million instead of 0 out of 1 million. So that means 1 out of 10,000 cells is a myeloma cell. what will you do about that? You have only 1 in 10,000. Now what? And the answer is, I don't know what. And exactly, it's that doesn't impact the treatment. And I guess it isn't something to lose sleep about.
Yeah, we all have patients who are 5-10 years out from their transplant, or we've been following them where they have not an insignificant amount of circulating myeloma protein, and they're doing just fine for years and years. So I think less cancer is better than more. So I think there's no doubt about that. But how we use this test to change treatment, we're not there yet, despite what some may tell you.
Can you give us your opinion on blood measuring MRD through the blood versus bone marrow? Are they comparable? Where are you?
It's a great question. It would be the holy grail of looking at the myeloma in terms of depth of remission. It's really in its nascent stages. Like we've talked a lot about, I mean, it would be lovely to not have to put patients through bone marrow biopsies and be able to do all this with the blood work. But again, it's a very heterogeneous disease. The technology is really not there. It's in clinical trials. So, it would be an exciting development in the future, but certainly not something that is used in real time now.
I am delighted to disagree. So the technology of measuring proteins, that technology is approaching year 100. When the way in which your proteins are measured is they're actually separated based on their electrical charge. And the idea is that the myeloma proteins all have the same electrical charge, and you're able to measure the level of the protein. By measuring with charge, you can probably get down to 200 milligrams per deciliter. Just remember the number 200. The next step was immunofixation. So that was introduced probably mid-80s. That actually increased the sensitivity tenfold to 20 milligrams per deciliter. Then the light chain came in, which gets you 10 times more to 2 milligrams per deciliter. But now there's techniques where instead of trying to separate the proteins by charge, they're separated by weight. And when you separate them by weight, the sensitivity shoots up. And so we've seen patients where we can't find 1 cell in a million in the bone marrow, but looking at that weight, because we know what the weight of the myeloma protein is. We know it from our original, and we can still find that protein. I find that disturbing, of course, and makes me wonder, well, is that just hanging around the protein, or is actually, I can't find 1 in a million, I'm still seeing the protein. It really is there, and it's a very sensitive technique. The point being, it's a blood test instead of a bone marrow. We have a paper coming out in amyloid, which is a related disease to myeloma, that if we can't find the protein in the blood using the weight separation, the results of the bone marrow don't matter. If it's not there, it doesn't matter if the bone marrow shows or doesn't show. The results are really very, very good. And I deeply believe that 5 years from now, MRD is going to be done on a blood test looking for the original protein by weight, rather than trying to sort a million cells and look for the malignant cells. Obviously, that's not validated. That is not widely used. The standard is still the bone marrow, but this business about looking for the protein by ultra high sensitive techniques, not by its electrical charge, by its weight, I think is, it's big.
It's a great point. And you're the technology that he's referring to, I think the difference in other cancers, we hear a lot about circulating tumor DNA, and that is a very different test. So I agree with Dr. Gertz. I mean, I hope that's where we're heading in the future. Again, the applicability to routine clinical care, I think, will be a challenge, but certainly for patient care, I think that would be a huge step forward.
This is literally a question that was asked in the very first patient family seminar I attended with Maury Gertz speaking in October of 1998. You'd mentioned taking, and you'll see what there's, you mentioned patients should take calcium and vitamin D. What's the recommended dosage? Are there other supplements or diets recommended? Has there been any research in the effectiveness of turmeric or curcumin, which is mentioned on many online cancer sites? I am newly diagnosed with smoldering myeloma.
Well, Dr. Gertz answered his answer from 2 decades ago probably still stand. So truth is we don't really have a great supplemental tool. Like I cannot recommend supplements that patients must take to decrease their cancer growth. But I think when it comes down to helping the body, repairing the damage that the cancer has caused, we know that bone is such a primary organ that's under attack by myeloma. And unfortunately, excessive bone loss oftentimes is not completely reversible. So at the very least, you'd want the calcium, the vitamin D to be sufficient. Vitamin D also happens to be functioning outside of the bone in the muscular skeletal system. So beyond those, check for vitamin D level. If it's deficient, replace. When it comes down to supplements though, most of them are actually trying to attack the cancer cells by functioning as antioxidant, sort of help boosting up the immune system in a nutshell. The downside is oftentimes what you get over the counter just doesn't have enough of the very concentrated material as scientists were using in the lab. So I'm not opposed to my patients taking supplements, but I think it's also important that as they're going on their therapy, that they share that information with their doctors. Some over-the-counter stuff could have some kidney toxicity, some liver toxicity. You really also don't want to have a drug interaction that would decrease the chance of the cancer medicine working. It's been studied, kind of survey, that majority of patients, more than 50%, are on some form of supplements. Just share the information with your doctors. Okay.
Oh, come on. I mean, the level of evidence of turmeric and curcumin, you tell me your opinion's different, is right up there with hydroxychloroquine for COVID-19. I mean, it's been around for 25 years and I can't think of one credible publication I've seen in 15 years that is supportive of the use of that. It's very widely disseminated on the websites and you know what? You don't mind, and it's your money, you know, because I don't know of any toxicity. But I mean, if you want to think that you're helping yourself with turmeric and curcumin, I'm not here to dispel that, but I don't know of any scientific basis from the original in vitro studies that are now 20 years old with nothing supportive of it to suggest that that is somehow killing myeloma cells or boosting your immune system or God knows what. But yeah, I have an opinion.
I would just say, be careful. There's a ton of stuff that people take over the counter that can have very negative consequences and can interact with other drugs. So yeah, definitely no to curcumin. Look, there's a lot of stuff we don't know.
What about, could you use the example of green tea?
Oh yeah, so like induction of like hepatic enzymes and inhibition of it, it's like the way a lot of our drugs are metabolized. So you will cause yourself a problem. So yeah, a lot of people do it. Tell your doctor before you do it, and they may have strong opinions and there's a reason.
So again, what is green tea? Green tea is the tea leaf, but instead of being roasted the way leaves are normally roasted into brown or black tea, you just don't roast it at all and you just pour boiling water on it. Yuck. Who here drinks green coffee, where they take the coffee beans and don't roast them and then grind? It's the same thing. You grind the green coffee beans, then you pour hot water on them and don't roast the coffee beans. It's the same deal, you know. And so there's a lot about the chemicals in green tea, and it's really great sales for Lipton and the like. But in terms of where's the scientific evidence in support of green tea for any disorder, heart disease, stroke, any cancer, I don't know where that is. But I mean, like, I don't know, 70% of the population drinks green tea once in a while, although I'm not one of them.
I think there's a true example of good intention goes wrong. One thing that came to mind was people who were on high dose vitamin C and take bortezomib or Velcade. So there's been some data to show that you could actually have the vitamin C binding onto the molecule of bortezomib, and then it doesn't work. So good intention goes bad, hurts more than help. In general, I usually just recommend my patients to be sure that they're staying on healthy diet and definitely physical activities. I don't think that there's a magic supplement that could replace all of the good things you'll do to your body.
I love to ask that question because in October of 1998, Dr. Gertz gave pretty much the same answer. But we didn't know about hydroxychloroquine.
I think you just got to
though.
tell your, we sometimes gloss over supplements and things that are not on our traditional MAR or medication list. So just be honest and communicate with your doctor what you're taking outside of the scope of what we're actually prescribing for you.
And with that, can we, we'll ask. We shouldn't, but we will.
You mentioned about the supplements, but I just wanted to have a quick question about in terms of just normal berries, strawberries, and those type of things that and the vitamin type ingredients that is in them. Do you see them the same way?
I mean, I think you're referring to what we were just talking about in terms of just a good, well-rounded, healthy diet. I mean, it's so simple, right? The best-selling weight loss book of all time would be Exercise More, Eat Less, right? I mean, it's really simple concepts. And, we just mentioned physical activity. So good physical activity to strengthen the paraspinal muscles, to increase your cardiovascular capacity. So it's very simple, but it's probably the most effective thing. So the only thing with fresh fruits and vegetables I would make a comment is after you've had a transplant or you're really immunosuppressed, you have to be a little cautious with that. But once your blood counts have normalized, then there really is no restrictions, in my opinion, at least.
I certainly rank berries above Fruit Loops.
What about green strawberries?
Green? Yeah, let them ripen a couple of days. I love strawberries and I love berries.
With that, I'm going to say goodbye to our so long to our online audience. We're going to take a 1-hour lunch break or a little less. We will be back at 12:45 Central Time. Figure that out in your own time zones. So we'll see you in a little bit.